Well, my name's Darrel Bowe. I'm a respiratory therapist. I'm also a polysomnographic technician, which is just a really, really long and fancy way to say I did sleep studies.
Sing in the mic.
Singing this? Okay,
Yeah.
there we go.
Yeah.
Is this better for everybody?
Yeah.
Okay. So I'm a respiratory therapist. Also am a sleep technologist. So for several years I did sleep studies for CPAPs and BiPAP patients. And then I got into respiratory therapy and actually worked here at Chippenham for a short stint. And then moved on to home care. Can everybody hear me okay now?
In and out.
It's in and out. We'll try to make it better. So I'm here today representing Med Inc. or COPD 360 Solutions, which is just a comprehensive respiratory program that we offer. So as you know, or probably know, COPD is a large umbrella. So it actually encompasses several different types of diseases such as emphysema, bronchitis, asthma. So all of those things can be lumped under that broader category of chronic obstructive pulmonary disease. This needs to go up.
Just
Louder.
get a little louder.
It's really hard to get it close to me, but
Darrel, do you want me to hold the microphone? Will that help?
I don't know. I'm going to try to get it held up here, so maybe you can hear me better. So, Med Inc. was founded in '99, and for that period of time, we did complex rehab, and we worked primarily with ALS patients and Lou Gehrig's disease. We still do that. That's still a major part of our company, and we have a lot of time and heart invested in that as well. So we work with the University of Maryland, Duke University, VCU, George Washington, as well as UVA. So we go to all of those different hospitals and universities, and we help with their ALS clinics for their patients, primarily in the way of rehab and respiratory therapy management. A little over 4 years ago, we were approached by a pulmonologist here in Richmond to see if there was any way that we could help patients with chronic obstructive pulmonary disease. So we took a while, probably about the first year and a half. We just did some research. We took on very few patients because we weren't really sure how this was going to operate and what it would look like. And from that point, we developed a whole program based around that. So this is just some data, if you want to know. But just so you know, there's been a steady increase of patients with COPD over the past few years. So this is from the GOLD initiative, and if you're not familiar with that, please come see me afterwards. I can point you in their direction. But it's this is the chronic obstructive pulmonary disease on a global effect. So it's a really great organization. So if you want more information about it, please let me know. They have lots of facts for COPD. And it goes, like I said, it's over the entire world. So it's one of the standards that we use within respiratory care and hospital management as well. So as you can see, from 2001 to 2012, this readmission rate has gone up quite significantly. So I'm going to get away from the microphone. Can everybody hear me? Okay. So as you can see right here, for 30-day readmission rate, we went from 2001 from it being right around 8 million on up to about 20. So it's steadily increasing as it goes up. So the number of patients with COPD that come out of the hospital and are discharged have a significant increase of getting readmitted within the first 30 days. So that's usually right around 23%. We actually think that that's higher with patients with stage 3 and stage 4 COPD. So this study did not break it down based on patient staging, but it based it just purely on the diagnosis of COPD. So we actually think that rate is higher for people with more severe forms of the disease. It's at least 80% within the first year. of getting readmitted to the hospital for the disease and complications with it as well. There's also some facts on there about the cost involved with that as well, and so we'll get to that a little bit later. But this is where our company sort of stepped in and developed a program called COPD 360. And what we found most of the time is that patients, when they're discharged home from the hospital, they have several different things that they're juggling, okay? So one of those things is my medications. The hospital just discharged me with a bunch of medications. I was already on a bunch of medications before I went into the hospital, and what do I do with all these, okay? What do I do with my home oxygen? What do I do with my home nebulizer for breathing treatments? I can't get in to see my doctor for 3 months. My pulmonologist doesn't have an appointment opening for 3 months, and that's if you're lucky. It could be 6 months or 9 months. So our company actually takes this sort of model and we try to manage it as best as possible for the patient. Okay, so instead of at any given moment you feel an exacerbation coming on and you feel like your only outlet is to call 911 or to call your healthcare provider, we actually offer a 24/7 on-call service with this company, and we try to help you manage that. So we give you medication oversight with our nurses in the home. We have home OT and PT, so physical therapy and occupational therapy, and as well as home respiratory therapists. So this is not meant to replace any sort of pulmonary rehab or any sort of pulmonary doctor consult. This is just an added measure to help with managing your care at home. So part of that we give is the non-invasive ventilation. Mr. Counts was so kind to mention earlier. So how many of you are familiar with CPAP and BiPAP machines? Okay, good. Good deal. How many of you have been hospitalized and placed on the hospital version of that? Okay. So I'm gonna grab my show and tell. And I'll leave these for everybody to take a look at after the meeting's over with. But these are just two of the units that carry that we use. So after getting into this, and non-invasive ventilation has been on the market for home use for probably the past 6 to 8 years. Okay, so normally what would happen is a patient would get exacerbated at home, and you feel like you couldn't breathe, and then what you do is you go to the hospital. So the only thing that the hospital did significantly different was they placed you on one of those hospital BiPAP units. So the reason you went is because you can't breathe, and so they probably placed you on some antibiotics and steroids, and then put you on their hospital version of a BiPAP. So that's what they do. So before, that care was not offered in the home. They didn't have those devices for home use, so you had to go to the hospital to get that. Now we have them for the home. So like I said, about 6 to 8 years ago, they came out with the Trilogy device, and since then they've come out with the second one, which is called the Astral. So this has been out for about 2 years now. And so what these devices allowed us to do was actually provide ventilatory assistance in the home. So you could actually get through an exacerbation, you could actually be assisted with your breathing just staying at home. So you can take a steroid, you can take an antibiotic at home, and now you can even get ventilatory assistance at home as well. So the big idea behind this is, a CPAP machine is a constant pressure that just blows in. It's just one set pressure. A BiPAP is just 2 set pressures, okay? So one for when you breathe in and one for when you breathe out. The difference in these devices is we set what they call a tidal volume. So if you think of a 2-liter bottle of Coke, if you were to crush it down, and then if I was just trying to blow into the 2-liter, without a certain amount of pressure or volume, I couldn't actually expand it all the way, okay? So I'm just blowing air straight in and it's not actually expanding all those little nooks and crannies, which is how your lungs operate. Okay, so if your lungs have a deficiency in the small little sacs of them that actually kind of crinkle them up, and so what we're doing is we're providing enough volume to expand that and really pop open those small sacs of the lungs. So without that volume, the BiPAP and the CPAP don't actually produce the same effects. You need that volume to pop open those small sacs so that you can get oxygen in, you can get carbon dioxide out. Does anybody have any questions on that? There's a lot of information.
Can I say something? It's not a question. When I came home from the hospital, my CO2 was above 50%, which is not real good. After using the Trilogy for a while, my CO2 levels are now in the high 30s to low 40s. So the exchange is greatly enhanced by.
Oh yeah, it's a big significant increase. Yes, sir.
Does this stuff only work with COPD?
So, it's a great question. Most of the time for interstitial lung diseases, such as pulmonary fibrosis, they usually don't order this form of therapy because that disease affects the lungs in a sort of different aspect.
Can you use the mic?
Yeah, sure. So this gentleman asked, was it just effective for COPD or anything like that? So normally for interstitial lung diseases, they don't order this type of therapy. We have had a few patients on it with pulmonary fibrosis, but usually that's in the case of they have some other comorbidities that is affecting them to retain CO2. So it doesn't help in the same. It doesn't help in the same way. It definitely decreases work of breathing. That's for sure, but it doesn't exactly work in the same way. As far as for neuromuscular diseases, we do take on myotonic muscular dystrophy patients as well as ALS and Lou Gehrig's disease patients. And we do have significant outcomes with that as well. So normally with neuromuscular or progressive muscle diseases, your diaphragm tends to stop working as well as it did. And your vital capacity or your lung capacity goes down significantly. And we've seen with these devices with non-invasive ventilation that it increases it within about 40% of most patients. Is there another question?
What's the different volume?
So the volume, you mean?
Say, between CPAP machine and
So CPAP machines and BiPAP machines are just pressure oriented. Okay, so think of your car tire holds a certain amount of pounds per square inch, right? Okay, so that's a volume in your tire, and it takes a certain amount of pressure to get to that volume. With BiPAPs and CPAPs, there's no volume set. It's just pressure oriented. So you're just getting the pressure. So we never actually know if we're getting enough volume to expand your lungs fully. Whereas these machines we actually calculate that volume based on your ideal body weight and your height. And so we get that figure, and then these machines will actually auto-adjust. So if you need more, it will increase as you need more. Did that answer your question?
And you can actually feel it when it does adjust.
Yep.
If you don't have a problem with the COPD and those little balloons aren't all crinkled shut and crinkled and messed up, and you get on one of these Trilogies,
Mm-hmm.
is it that you really don't need the Trilogy to do that extra expanding? Because I know it wore me out. I couldn't take it.
Yeah, so it also depends on who's working with you with the device too. Okay, so with most neuromuscular disorders, it actually does help to exercise the diaphragm. So it probably wore you out because number one, it may have been too much at first, but number two is probably exercising your diaphragm, which is a muscle. So there's
Only half of it.
so you have a paralyzed, partial paralyzed, yeah.